Okay, welcome back to the next episode of the WashU Nephrology Renal Path series. We are here again with Dr. Gaut and our second-year fellow, Karthik, and we're going to walk through a case for you guys. So, it's a brief case presentation, probably more than Joe is used to getting as the pathologist, but we'll give him a little extra. So this is a 55-year-old female with type 2 diabetes, which has been well controlled for about 15 years, hypertension, and unfortunately recently diagnosed breast cancer. She had a lumpectomy and local radiation 3 months ago. She's being evaluated by nephrology for proteinuria. Her medications include insulin. She's on lisinopril, 10 BID, aspirin 81 milligrams a day, and amlodipine. Her blood pressure is relatively well controlled. She has 1+ edema, but otherwise an unremarkable exam. So let me give you some details about her renal function and her proteinuria. So her creatinine is relatively stable, 1.2 with a baseline 1.0 last year. Her hemoglobin A1C is 7.1%. Pretty good. We can do better, but still pretty good. She has 2+ protein, 2+ blood, and a protein to creatinine ratio of 3 grams per gram. For reference, she has had UAs kind of over the past 5 years, all of which have shown traced to 1+ protein, but the last time the microalbumin to creatinine ratio was checked a year ago, it was only 500 milligrams per gram. So I don't want to belabor the point, but this patient was biopsied because even though she had a strong history of diabetes and proteinuria, there were a couple things that were, red flags to us. The big jump in the proteinuria, and the fact that she had this recently diagnosed breast cancer made us think, could we be dealing with something else? So to jump to the literal meat of the case, she was biopsied for those reasons. And so I'm going to hand it over to Joe to walk us through this biopsy.
All right.
So this is again a trichrome stain. We're looking for chronicity in this. I see more blue towards the lower portion of the slide. It's could be either edema or if it's thicker blue, it's fibrosis. It looks to me more like fibrosis rather than an edema. I would say about 25% of it is fibrosis.
Yeah, so this is trichrome. We're certainly looking for fibrosis in this case. It's a little bit of a lower power view, and you can see there is certainly quite a bit of fibrosis. Some things you can see the tubules are not back to back.
Right.
They are spread apart by all of this relatively dark blue staining. I would consider this dark blue as representative of fibrosis in this case. Now we have a little bit more down here. You see a larger artery, so we're probably close to the corticomedullary junction here, but this is pretty significant. I would say this is moderate, maybe severe if we looked at the rest of the biopsy. There's quite a bit of chronic damage here.
Okay.
So this is not something that happened overnight. But we're expecting some degree of chronicity with this patient's history. So it's at least in the moderate category, just looking at this one representative image, which would be in the 25 to 50% range.
Okay.
Okay.
This is a H&E stain, and I'm looking at the interstitium and one glomerulus in the 11 o'clock position. There is the tubules are not back to back, and there is a lot of interstitial fibrosis. In the glomerulus that I see, there is diffuse thickening of the glomerular basement membrane. It's hard for me to tell, and the capillary lobes appear open.
What about this big thing here in the top part of this glomerulus?
It's a nodular appearing fibrotic structure.
Right, we have this big nodule. So, and then you have these kind of cells around the periphery and maybe a little fibrin cap out at the outside, right? And yes, I agree, these do look a little bit thick. With PAS, it's better to assess thickness, as we've discussed in the past. But the main thing, we do have this large nodule. This is likely a globally sclerosed glomerulus over here, although we might just be getting into the top of one. And you can see that interstitial fibrosis and tubular atrophy at this point. Some other things to point out. Here's an arteriole right here, and you can see some arteriolar hyalinosis,
Right.
which non-specific, but you can see that in diabetes, you can see that in hypertension. Not on calcineurin inhibitors for any reason, but chronic calcineurin inhibitor toxicity can also lead to that type of a change. But this big nodule is kind of the smoking gun. So do we have other
Yes,
light microscopy?
here's a higher power of an H&E, kind of looking at a different glomerulus.
Again, the similar appearing nodule, there are almost two of those next to each other with eosinophilic stain appearance. And again, the GBM in this also is difficult to identify, but it appears thickened. There are no inflammatory cells that I see, and the capillary lobes appear open in this as well.
Right, so we have the main pattern here is a nodular glomerulosclerosis,
All right.
correct? So in your mind, just looking at this pathologically, what is the differential diagnosis when you see nodules on a biopsy? So obviously diabetes, okay?
Right.
1, 2, 3 diabetes, okay?
And do you know what those are called?
Kimmel-Steele-Wilson
Great,
nodules.
great.
Very good.
Mhm.
So diabetes, what else might cause nodules?
Infection associated.
Not typically. That can lead to maybe a membranoproliferative type of appearance. So what other things can cause? So really the nodule is just a big ball of collagen. So what
Right.
else can cause things to deposit in the mesangium and that might happen to have a nodular appearance? So think of things that deposit stuff in there.
Like amyloid.
Amyloid, exactly. Amyloid can definitely mimic nodular glomerulosclerosis due to diabetes. So it's something to keep in the back of your mind. And typically these patients are usually older at the time of biopsy and fit sort of the demographic profile for that. So amyloid, what else?
And other deposition diseases like fibrillary, immunotactoid. Those
The
can
weird ones, the rare ones that we usually don't see very often, but things like that. So other medical diseases that can cause this, things like gout can cause nodular glomerulosclerosis. There's a few reports of that. But the vast majority of the time, this is related to long-standing diabetes. Now, what other stains are we going to want to look at in our routine set? We always get the PAS. We always get a silver stain.
Right.
We always get a trichrome. So what are we going to be looking for to make us more or less suspicious for amyloid on these other stains?
So Congo red stain would be one.
Well, the
and,
Congo red, we can always order the Congo red. But what about on the PAS? If it were amyloid, what would be looking for here on the PAS stain?
So it would be a PAS negative.
Yes, PAS negative.
Negative.
So PAS negative material, you've got to start worrying about amyloid or something else being deposited there that's not collagen. And then silver?
If it's diabetes, it would be strongly silver positive, and if it was amyloid, it would be negative.
Yeah, it's usually silver negative. Sometimes the silver stain is a little variable, and you do have repeated rounds of mesangial lysis in these cases of diabetes. So it's a little bit not quite as good as, in my opinion, as the PAS. But typically, for teaching's sake, you assume that those are silver positive. Okay.
And there's also this, this idiopathic nodular glomerulosclerosis, which occurs
Forgot to
in
mention
some
that one. Yes.
people who smoke, right?
So it's older white men who smoke
Okay.
get ING, idiopathic nodular glomerulosclerosis. Nodular glomerulosclerosis. So, yeah, that's another one that can happen. We have to always include the idiopathic one, and it's older white men who smoke. So, but this is not that case, right?
Right. All right.
All
So
right.
here is
What stain is
more of the
this?
stains.
PAS stain with strongly positive in the nodular appearing structures.
Very good. So now amyloid's dropping down,
Lower on the
dropping
list,
down
yeah.
on the list. Yes.
So if this were amyloid, would that be just clear, or would
It's
it would it
very,
still just
very
be a very
pale.
light,
Very, very-
PS, lightly positive?
Very weak,
Weak positive.
very light shade of pink.
Okay, as opposed to this, which is obviously
Right. It wouldn't be completely
strong.
white,
Yeah.
but it would be very weak.
Okay. And so here's the silver also.
So silver stain, again, we are seeing positivity in those nodular appearing structures, more blackish.
Very good. Yep, that's the main thing here. Now, other things can coincide with diabetes. So it could be diabetes plus something else. I mean, if the proteinuria shot up and it was quite high, you could have diabetes plus a membranous.
Membranous, right.
Right, so in membranous cases, what would we expect to see?
We'll see spikes on silver stain.
Exactly, so you'd see spikes right here out in the periphery of the capillary loops on this silver stain, which stain the collagen that's present in between the immune complex deposits, which are silver negative. But we don't see any of that here. This looks like a fairly straightforward case of diabetic nodular glomerulosclerosis.
Okay, and one last just interesting finding on light microscopy before we move on. I'll let Joe kind of hopefully lead the way here.
Okay. What are we looking at here, Karthik?
So this is again a PAS stain.
Yep.
We're looking at tubular basement membrane
Mm-hmm.
and
What am I circling here? So look at these cells. You see all the nuclei?
right.
And this one doesn't look like the rest. He's sticking out like a sore thumb. It's kind of,
It's
what is this?
bilobed structure.
It's not bilobed, so this is a, think back to biology back in college when you were looking at cell division.
Mitosis.
This is a mitotic figure.
This is
Exactly.
mitosis
This is a
in action.
mitotic figure. And so what does that signify here? Is it just fun to look at, or does this have some sort of meaning when it comes to mitotic figures and tubules?
They're working hard to.
They are working hard.
Yes.
They are
Regenerate.
They are regenerating, and you see the increased levels of mitotic figures in acute tubular injury.
Okay.
So there's
Interesting.
undoubtedly a degree of tubular injury in this case. Might account for some of the rise in creatinine.
Okay.
We don't know what caused that.
So we're thinking, based on light, that this is really suggestive of diabetic nephropathy. Do you know what is typically seen on immunofluorescence in diabetic nephropathy?
They should not be having any immunopositive staining.
So it's not immune complex mediated.
right.
But I'll show you what we're going to find.
Let's see what we see.
So
And
this,
then you
is,
see
this
it-
is what we have. So
All right.
Just describe what we're seeing. This is IgG.
So IgG, it's staining the capillary walls,
Mhm.
and
Mhm.
it's linear.
Right.
Oh, right. So
And then what about out here?
What those tubular basement membranes
Right.
with positive IgG staining.
mhm.
Very good. So we have linear glomerular basement membrane and tubular basement membrane staining for IgG.
So this
So-
is not anti-GBM disease, which also does that.
Right.
But this is a typical finding in diabetic nephropathy
It's
to
a-
have
it's a-
linear IgG.
It's a typical finding. It's non-specific related to, proteinuria,
Okay.
where we're seeing this. So what other stain do we typically see in this, showing a very similar distribution?
So linear IgG distribution and anti-GBM disease.
In diabetes. So there's
Oh.
another stain on our panel where we'll see the exact same pattern, which
Oh.
won't be present if it's anti-GBM disease.
IgM.
So, or if it's anti-GBM disease, so that would be albumin. Will also stain, just like this, linear staining of the glomerular capillary loops and the tubular basement membranes. Of course, in anti-GBM disease, you should have crescents
Right.
on the biopsy, so don't go over-interpreting the IF, but yes.
Okay. And one EM pick to round it off.
So that's the glomerular basement membrane,
Good?
and to the left of it, I'm seeing foot processes of the podocytes, and so that's the urinary side,
Mm-hmm.
and the one opposite is the blood side.
Okay.
So there is a measurement that I see. So
Yes.
Mhm.
So what's normal?
it's normal for it
What's
varies
the normal
for-
thickness of a GBM
for
for an adult?
adult male. It's between 200
A little more.
250.
Keep going up. So the average for an adult, male and female, it's a little bit more for male, a little bit less for females, but just keep one number. It's easier to remember one than two. 350 plus or minus 50 nanometers.
Okay.
Okay? Now this one is
600.
626. That's pretty thick, right? So that would certainly fit with our diagnosis of
Diabetes.
diabetes.
So just for my edification, what else thickens the basement membrane? Like Alports can do that, right? It can cause both thinning and thickening.
It's thinning and thickening, but typically in Alports, what you see is this basket weaving pattern,
Right.
different patterns.
Mhm.
And other diseases tend to cause more thinning of the glomerular basement
Mhm.
membrane, like an IgA.
Mhm.
Glomerular basement membrane can get more thin, certainly in cases where you have lots of chronic damage. And if we were looking at a segmentally sclerotic glomerulus and you see some wrinkling, sometimes that can appear somewhat thickened. Certainly membranous, the GBMs can be thick, but that's because there are these huge immune complex deposits present in there.
Okay, excellent. So, this, I felt like this was a nice case to kind of show all of the findings of diabetic nephropathy, which is what this patient ended up having. And just for one brief discussion point, rather than belabor what we've already gone through, because I think the biopsy shows, I think, all the high points of diabetic nephropathy, is that we don't always biopsy patients with diabetes because usually we find diabetic nephropathy, especially in adults. But there was a nice review in C. Jason, which came out of the folks in Colombia, which looked at all of the patients that had diabetes who had a kidney biopsy read in 2011 at Columbia. And it was kind of split into thirds. A third of them had the typical findings of diabetic nephropathy. A third had diabetic nephropathy and another kidney disease. And another third had something completely unexpected, which included a whole variety of things: ATN, FSGS, hypertensive nephrosclerosis, IgA, or membranous. So sometimes you biopsy these patients because there are red flags. In this case, the proteinuria shot up all of a sudden. She had a diagnosis of cancer, which made us worry about maybe something like membranous. So it's a nice review if you want to check it out. So that's that. I think that's a good review of diabetes. We'll be back again for more cases. Thanks again for tuning in. Follow us on YouTube at WashU Nephrology, and we will see you next month.